Okay, well, let's get started. It's exactly 9 o'clock. So I'm Raj Dave from Camp Hill, Pennsylvania in US on behalf of C3 Live. And it's my great honor and privilege to have an immensely talented faculty today. It's going to be some very, very interesting topics. Some of them, we have not routinely heard before, and I think it's going to generate a lot of good discussion. Um, our first speaker is Dr. Nihar Desai, who's Associate Professor of Medicine, as well as Vice Chair of Cardiovascular Medicine at Yale University School of Medicine. He's also a senior investigator at the Center for Outcome Research and Evaluation. And he is one of an incredible stars. His career is just really rising, and he's really well sought out all over the country as well as world, and a close friend, and has been in a tremendous part of C3 for last 10 years. And today's task is to talk about optimal management of LDL cholesterol. He's going to talk about a lot of exciting things. So I'm going to turn over to Nihar.
Wonderful. Thank you very much, Raj. Delighted to see you all, and thank you for making time on a Saturday. For those in the U.S., I know we're heading into the holiday season, and sounds like many around the world are also celebrating, special times and a holiday season. And heard a wonderful story from Bangladesh. So, thanks to all for joining. I hope you and your families are all well, and delighted that we have a little time together. And so, like Raj said, my task in the next, 25 minutes or so, I wanted to give a quick update on LDL cholesterol, sort of where are we heading? And I thought that we'd sort of tackle that on two fronts. These are my disclosures here, sorry. That we'd sort of tackle that on two fronts. We'd sort of very quickly, I think, cover primary prevention. I know many of us are seeing patients that have established disease, polyvascular disease, multi-vessel disease, very high risk patients. But I think, it is good just to kind of quickly review primary prevention. We'll go into the guidelines there. I'll spend most of the talk, though, on really thinking about where we are and where we're heading on secondary prevention. What are the therapies that are available to us? How do we think about those therapies? And then what might the frontier actually be in terms of LDL? So we'll start here, and I think it's always good to go back to this. I know for too many of us, we see patients at the far right-hand part of this slide, but I think this slide is nice because it reinforces that lipids, and especially LDL cholesterol, are very central to the pathobiology of atherosclerosis and vascular disease. These are data that are now almost 20 years old. These are data from the InterHeart study from Salim Youssef and the group in Canada. It was a global epidemiological study, but InterHeart asked a very interesting question. It said, hey, of all the risk factors that we know about for cardiovascular disease and myocardial infarction, what's the relative importance or relative contribution of each of those? And sure enough, all of the things that we spend time talking to our patients about are represented on this slide. But I would, urge you to look at the far right-hand part of this slide, that lipids actually have the highest population attributable risk. And again, for all of us, that might not be a big surprise, just given the last slide that we looked at, where we said, kind of reviewed the central role of LDL cholesterol in the pathobiology. But the global epidemiology then follows and parallels what we know from pathobiology and basic and translational science. So when it comes to sort of primary prevention, I think the habit, I think, for all of us is we've got to get into some objective assessment of risk. And so this is the ACC-AHA pooled cohort equation. There's a tool like this for the computer. There's one for your cell phone. Many of these are now integrated into the electronic health record systems as well. And so this is just, some data that I've inputted. And what this then outputs is the 10-year risk estimate at the very, very top part of the slide. I think the other number that's very important to engage our patients around is actually right below that 8.3%, which is the optimal ASCVD risk. So that's the number if we get everything right. That's what I say to our patients. If we get your blood pressure optimized, we get your cholesterol optimized, stop smoking, get you on appropriate medical therapy. And I think that delta, in this case, between 8.3 to 2.5 can be very helpful to a patient as they think about the care plan that we are talking about and then ultimately adhering to that care plan going forward. So with that as a backdrop on the primary prevention side, we sort of dive into the guidelines. This is the latest version of the ACC/AHA guidelines on primary prevention. I think there's a lot here, and so I want to quickly kind of walk you through this. But if you start in the upper right-hand part of this slide, if you have a patient that has an LDL above 190, or a patient that has diabetes and aged 40 to 75, you don't need to calculate any 10-year risk. You don't need to do anything else. There's a class 1 indication for starting statin therapy, either high intensity or moderate, depending on which clinical cohort you're talking about. In fact, there's a 2A recommendation for using a high intensity statin in all patients with diabetes, regardless of their sort of other risk factors. If you go forward and say, what about the patients without diabetes? So then we sort of wind up in this middle bucket here, age 40 to 75, LDL 70 to 190, no diabetes. That's where that 10-year risk assessment really starts to guide clinical decision making. You wind up in either a low risk, a borderline, intermediate, or high risk. And I think the one important point that I would make for this group of patients, if you wind up in this area, especially in intermediate risk, is to go to the left-hand part of this slide and look at the risk-enhancing features that the ACC/AHA guideline has specifically called out. There are some very important things there. For example, chronic kidney disease, metabolic syndrome, some conditions that are specific to women. We have to take a very comprehensive history if we're really doing primary prevention and evidence-based decision making. Inflammatory diseases. Does the patient have rheumatoid arthritis, psoriasis, or other conditions that we know are associated with accelerated atherosclerosis? And for the first time, the guidelines actually called out ethnicity, South Asian ancestry specifically, as a marker of elevated risk that should be integrated into our decision making about primary prevention of cardiovascular disease and the optimal role of statin therapy. If a patient asks, this is a meta-regression that summarizes a number of important kind of seminal clinical trials in terms of lipid lowering. The primary prevention trials, which we're focusing on now, are in the yellow there. And of course, you can see that tried and true relationship. Lowering LDL seems to translate into reductions in risk. How much of a reduction? This is from the CTT, placebo versus statin therapy, primary prevention. If you look across major cardiovascular events, different subtypes stratified in this figure, but overall for major vascular events, about a 21% relative risk reduction with statin versus placebo on the primary prevention side. And so that was sort of a quick, just review of primary prevention. Again, I know many of us are not seeing those exact patients in our practices, but should something like that come out, then I wanted to just make sure that we kind of covered the latest in terms of the guidelines. So let's shift and kind of get into the secondary prevention side of things. And there's been a lot of activity, obviously, on this side of the coin as well. And so if we go back to this figure that we were just looking at and focus on the secondary prevention trials, you can see that we had sort of come to a place where we had gotten to an LDL of 70. And then we had these sort of two related questions that we had to answer. First, does further lowering of LDL translate into further reductions in risk? And relatedly, does the mechanism of the LDL lowering matter? Is this a relationship that's special or unique to statins? Or does this relationship hold for all therapies that lower LDL cholesterol? And so I want to sort of take us up to speed and then review the latest guidelines and consensus statements that have come from the professional societies because again, there's been a lot of action and activity on this side of the coin. The first trial to very quickly review is Improve It. And so this was a large trial, 18,000 patients. It's actually old now, almost 7 or 8 years old. Patients stabilized post ACS, randomized to Simva or Simva in combination with Zetamib, which blocks the intestinal absorption of cholesterol. In this trial, there was a modest delta in LDL between the Simva monotherapy and the combination Simva Zetamib arm, got from 70 down to about 54. And with that modest delta in LDL, there was a modest reduction in cardiovascular events. There was a broad primary endpoint here, about a 6% relative risk reduction. This is not a big reduction in events. This is not a big delta in LDL. But I think for the two questions that we laid out at the beginning of this section, are incremental reductions in LDL below 70, are they going to translate into reductions in risk? And do non-statin therapies that lower LDL confer that same reduction in risk? Improve It was a very important trial in terms of answering and helping push the ball down the field along those two primary questions that we had raised. To get to bigger reductions in LDL, that's really where we get into the PCSK9 inhibitors. And so I've just very quickly shown this figure and schema here of PCSK9 in purple, that monoclonal antibody in red. And when you have that monoclonal antibody against PCSK9, you allow the normal recycling of the LDL receptor to happen in the liver. And that LDL receptor then can bind another circulating LDL cholesterol particle. And that's essentially how we clear LDL cholesterol from the bloodstream. I think what got a lot of enthusiasm in terms of the development of the PCSK9 inhibitors is shown here. So this is genome-wide or Mendelian randomization data that actually looks at some individuals by sheer good luck, by the gene they got from mom and the gene they got from dad, have two alleles for PCSK9 that code for low protein expression. And it turns out, if you look at that sort of natural experiment, that Mendelian randomization, if you look at those individuals that have those kinds of alleles, that have low levels of PCSK9, it turns out that they had a 60% relative reduction in the risk of myocardial infarction. And so this really then, I think, even had more enthusiasm in terms of the clinical development of the monoclonal antibodies and really spurred that development along. So of course, I'm not going to get into all the details of Fourier and Odyssey. I think most of us are familiar, but I wanted to just quickly have these slides so we can review the overall design. So we have the Fourier trial with evolocumab or Repatha. We have Odyssey outcomes with alirocumab or Praluent. Both therapies, of course, are available and I think widely around the world as well. There were some subtle differences in terms of the population that was enrolled, the LDL cut points, how the trial conduct was handled. But I think overall, the findings from the two trials are actually very, very consistent. So this is the LDL effects, Fourier on the left, Odyssey outcomes on the right. You can see about a 55 to 60% reduction in LDL cholesterol, depending on what time the measurement occurred and what trial you're talking about. And for that more dramatic delta in LDL cholesterol, we see a much larger 2% absolute for Fourier, 1.6% absolute for Odyssey outcomes, and about a 15% relative reduction in broad endpoints for the two clinical trials. And so again, if we go back to our two questions, is incremental lowering of LDL beneficial? And I think with these trials, we certainly have the answer to that question. And the mechanism of LDL lowering, now we have a truly novel mechanism, PCSK9 inhibition outside of statins, and then that data we saw for Improve It with Zetamib and the intestinal absorption of cholesterol as well. This is one of the, I think, really interesting and important post hoc analyses from Fourier. And so what the investigators here did was they essentially stratified the patients based on whatever the LDL was 1 month into the study. And you can see that sort of color coding there in the upper left-hand part of the slide of, whatever the LDL-C was at week 4, from the blue to the orange to the green, and then all the way down to the yellow. And then they followed those patients forward. And sure enough, as you would expect from the first slide that we talked about, the pathobiology of vascular disease and atherosclerosis, the data we saw from Interheart, those patients that had the lowest LDL cholesterol, so those in the yellow on this slide, 1 month into the study, they actually had a 31% relative reduction in risk. And you can see this kind of stepwise gradient of reductions in risk with each stepwise reduction in LDL cholesterol. And so now we've seen over and over and over in clinical trial after clinical trial, in epidemiological cohort after epidemiological cohort, and now mirrored again in this post hoc analysis from Fourier, that the lower your LDL, the lower your risk for recurrent events. Against all of that, the totality of that story, I think it's pretty incredible to think about where we've come over the last, 25 or 30 years in terms of LDL cholesterol. Many on this call will probably remember the days of 4S, when in the early 1990s, the question was, if someone has an LDL of 190, should we give them simvastatin? That was really the state of the science. That was a placebo-controlled trial. And think about where we've come now with Fourier and Odyssey, with LDLs in the 30 to 40 range, really clearly demonstrating clinical benefit for our patients. And so I don't think it's to anyone's surprise here, whether you look at the ACC/AHA guidelines in 2018, the ESC guidelines, which I think are much actually farther ahead than the American guidelines, and even the endocrinology guidelines, that professional societies are reflecting this emerging and accumulating evidence that has come for LDL cholesterol, and talked about getting to lower and lower LDL levels. So the American guidelines talk about this threshold. If you have a high-risk patient, their LDL is above 70, we should be reaching for non-statin add-on therapies. The ESC actually set a goal, say, hey, you got to get the LDL to less than 55. Sometimes, if it's a very high-risk patient, an extreme risk patient, they say an LDL less than 40, and similarly for the endocrinology guidelines. And so I think there really is consensus between the global guidelines. I do think the ESC is probably further ahead. And because of all of this evidence, and because the American guideline update is likely to not occur for another 18 to 24 months, the American College of Cardiology issued an expert consensus decision pathway last year, actually changing that threshold from 70 down to 55. And so now, again, I think we're seeing some harmonization here between most of the global professional societies. And again, I think the takeaway message is really, we should be really aiming for much, much lower LDLs, especially for our very high risk patients. So in the last couple minutes that we have together, I just want to kind of walk you through some of the emerging therapies that have come on to the scene. This is a nice review article that kind of talks about lots of therapies and shows the mechanism. Bempedoic acid acts one step upstream of where the statins act in that pathway of cholesterol biosynthesis. And we've seen some important data earlier this year presented at the ACC meeting in New Orleans. That was the CLEAR Outcomes trial. So this is bempedoic acid versus placebo in statin intolerant patients. And in that study, you saw about a 20% delta in LDL cholesterol, some reductions in high sensitivity CRP, as you can see in that panel B on the left, and then across a different a range of endpoints and different definitions, 4-point or 3-point or MI or REVASC, you can see anywhere between 23 to 13% relative risk reductions with bempedoic acid versus placebo. So I think an important complement to our armamentarium for LDL lowering now, including in patients that have statin intolerance, we have an evidence-based therapy intervention for those patients specifically. We've talked a lot about the PCSK9 inhibitor monoclonal antibodies. We also have some new approaches to PCSK9 inhibition. And I think the first one that I want to talk about is with inclisiran, which is a small interfering RNA, acts intracellular, and actually blocks the production of the PCSK9 protein in the first place. So I think we saw in the early experience with inclisiran about 50 to 55% lowering of LDL cholesterol. And then the most intriguing aspect of inclisiran is that in the maintenance phase, it can be administered every 6 months. The therapy, trade name is Leqvio, is obviously available now. I think many people are using it and have good experience with it. We're still awaiting some of the clinical outcomes data, which will come in the Orion 4 HPS 4 TIMI 65 trial. I think one of the important features of this trial is a long median duration of follow-up of almost 5 years. I sort of want to go back a little bit, just a few slides back. We were sort of talking about the Mendelian randomization, and we said, hey, there's some people that by sheer good luck got a gene from mom and a gene from dad that code for low levels of PCSK9 protein. And they, remember, in that Mendelian randomization, they seem to be really protected from developing vascular disease and myocardial infarction. And so there's a group now, there's a company that is actually essentially aiming to do that for everyone, that's saying, well, we can use CRISPR-Cas9 gene editing to actually modify the genome for everyone, to basically give everyone a DNA that codes for low levels of PCSK9. I know this sounds like science fiction, but I assure you it's not. But I will stipulate there's certainly a lot to think through here in terms of safety and ethics and how this would get ultimately implemented and paid for. But this is the state of the science. This is what's happening literally right now. In fact, for those of you that were at the American Heart Association meeting, you saw the first in human data for this approach, this intervention from a company known as Verve. And their hypothesis is that we essentially give a single course of treatment, modify the genome, essentially turn off the PCSK9 gene, and give individuals lifelong protection against atherosclerotic cardiovascular disease by lowering LDL cholesterol. And so the data that was presented at the AHA was actually in patients with heterozygous FH. There were 10 patients. This was a multi-dose phase 1B study. You can see the different doses there in the middle of this slide. And I'll sort of take you to the primary results, which are shown here. So on the left is the LDL reduction. So with the top dose, there was a 55% reduction in LDL cholesterol. And at the right, you can see that that was durable, at least for 6 months. So again, there's a long way to go, lots of work that has to be done, lots of thinking and lots of consensus around what does this approach mean? How do we implement it? And how do we make sure it's safe and effective? But this is the state of the science. This is really the kind of cutting edge, what's at the leading edge of the scientific frontier in terms of LDL. And so I'll just close us out with a couple of summary thoughts. ACC-AHA now recommend the addition of non-statin therapies in high-risk patients who have an LDL above 70. We talked about the expert consensus decision pathway, actually lowering that to 55, harmonizing much more with ESC. There's a growing number of non-statin therapies. We talked about bempedoic acid, inclisiran, of course, ezetimibe, and the monoclonal antibodies against PCSK9. Novel gene editing approaches to inhibit PCSK9 are in active development. We saw the FDA approval for sickle cell just last week. I will also say, though, at the tail end of my talk, while LDL is the cornerstone of hyperlipidemia management, there's obviously still substantial residual risk, even with those patients with an optimal LDL. And so I will say, stay tuned for things that are happening on the fish oil side, on the lipoprotein(a) side, on the triglyceride side. I think there's a lot of excitement in the field, and I think has important implications for the patients we take care of from both a primary and a secondary prevention standpoint. So with that, Raj, I'll turn it back over to you, kind of close out the formal part of the presentation. Wonderful to see everyone. And thanks again, Raj, for the opportunity to be with you.
That's great, Nihad. Thank you very much. Great talk. We have a fairly global audience today, and there is some comment from Dr. Shetty from India. Indian Lipid Association guidelines are probably even more aggressive than US and Europe. It's more of a statement than a question. Indian guidelines requires LDL reduction even 10 to 20 points lower than the Western guidelines. And I know there's a lot of excitement with this new injectable therapies in India now. So great to see that. Clearly, with the aggressive disease, coronary disease that we see in Indian population, it makes sense to be lower the better. Any other comments from the esteemed faculty members? Brian, you are a huge fan of inclisiran.
I am a huge fan of inclisiran. I was thrilled that, as a matter of fact, I'm going to try to shamelessly steal that pathophysiology slide because it's wonderful. The biggest thing here in the U.S., of course, is cost. And that has been the thorn in the side of lipid-lowering therapy from the time that we stopped mixing sand and orange juice and giving it to our patients back in the day. And so I think the big issue is for us is going to be how do we demonstrate to the insurance companies that it's in the long run worth their while to make this therapy good, and so that we don't have access to care issues or continue to have access to care issues.
Yeah, Brian, it's such an important point. I mean, I can't thank you enough, for those comments, because I think, we do face this challenge now of, we know where the evidence is, we know where the guidelines are, and hey, we have a whole suite of therapies now that can actually get us to where the guidelines want us to go. And yet we now have to confront the ultimate challenge and implementation of cost and access barriers to try and get these evidence-based therapies to all the patients who need them. I will say, at least in the US, I think access has gotten a little bit easier, a little bit more fair and transparent, which I think was the source of a lot of frustration early on with the PCSK9 inhibitors. I think we now have at least some guidance on certain high-risk features, certain things that we've tried, a certain LDL, we're likely to get them approved. But I think, to your also very good point, approval and access is just one thing, then cost and prohibitive cost is yet another. And so we have certainly lots of challenges to confront, on that side of things. I hope that our insurance system and our healthcare delivery system will kind of finally line up with where the evidence is and where all the therapies are, because there are so many events that could be averted if we sort of think about and focus on LDL. So I really appreciate your comments for that, Brian.
No, that's great. Nihar, I have one last question for you. Tell me what your thoughts are on the safety of this mRNA-based therapies. There's not a lot of, because that's the one question that I face in clinic all the time about patients ask me, what do I think of, what's the safety of this?
Yeah, Rod, it's a great question. So I will say it's probably the biggest thing that has slowed us down from a very rapid adoption of inclisiran. Not because of any concerns about efficacy. I think the efficacy is clear. The PCSK9 pathway is now biologically established. It's really around safety. And so the only reason that we've kind of only have, maybe a relatively small proportion of our patients on inclisiran, those that have adherence issues or have really been keen to get on it, is really around safety. And so that's where I think 5 years of follow-up to really make sure that we understand what's going on here becomes really important. So far, I will say that approach of siRNA in other therapeutic areas has seemed to be safe and effective. And so I think we can take some guidance from what we're seeing elsewhere. But I think it's really important for us to get the safety of these therapies. And as you know, that's also the mechanism for a lot of the lipoprotein little a therapies, is actually intracellular antisense oligonucleotides or small interfering RNAs. And so as we start getting into the genome and intracellular, I think we really have to make sure there's no unintended consequences.
I have to tell you that
I want to take one last question.
Yeah.
Dr. Harris now has joined from Malaysia. And his question is, Nihar, for you, is the absolute number reduction to target matter or percentage reduction in LDL is sufficient?
Yeah, man, Harris, what a great question. And I will say all the guidelines essentially have this notion of a dual target. There's that sort of absolute number that we should get to, but then also at least a 50% reduction in LDL. And so you are quite right about that. It's a very important point. The American guidelines and the ESC both have that sort of notion of dual targets. And so that's a very important point that you kind of raised there.
Great. Thank you so much, Nihar, for the great talk. We're going to keep moving here, the program. In the interest of time, we have lots of other questions. I'm going to try to answer some of them in the chat room and address them. But thanks again. Now let's invite Dr. Kirti Punamia from India, Mumbai. He's a senior consultant cardiologist and interventionalist at Breach Candy Hospital. He is well-renowned all over the Asian continent. He's done invaluable service to imaging and different additional modalities in coronary PCI in India. He's been an avid participant in C3 Congress for many years. And Kirti is also working on many book chapters related to calcified lesions in coronary arteries. So it's a great honor and privilege to have him here today. And he's going to talk to us about calcified coronary lesions and our choices.
Thank you, Raj, for inviting me on this podium. And again, apologies for my absence from last time, but quickly going to go into my slides. And how do I navigate this problem of calcium currently? I think as we all know, let me introduce this. As we all know, we assess calcium variously, like CT scans, fluoroscopy, and fluoroscopy being the gold standard in the cath lab. If it shows moderate to some echo, shows moderate to severe calcification, I think two important issues that we face are difficult to cross and difficult to expand. And I'm trying to make this talk very simplistic. It's something that I follow in my cath lab. We have evolved through various algorithms, and the current one, which I think is simplified to a large extent. So the big problem is difficult to cross is the first problem that we face with calcium. How do we assess it? We assess it by simply taking an imaging catheter, either IVUS or OCT, and check whether it crosses or does not cross. We don't try to force it into the lesion. If it does not cross, then the next thing is the microcatheter, whether it crosses or not. And given that both these don't cross, we have three choices in our cath lab: the ELCA, the Tornus Turnpico, or an ultra small balloon to go and dilate it and see if you can squeeze a balloon and make some room. Though, as I said, it's in a smaller font, and that's one of my last choices. The ELCA is a good choice to go to. Tornus has been a choice prior. The idea being to gain access into the artery, basically. And this is a case which kind of spells that out. It's a very diffusely calcified artery, severely calcified, with a subtotal lesion in the mid-segment and difficult access. We used guiding catheters with guidezillas to get access into the artery with a fine cross and a Fielder XTA wire. Attempted crossing, we couldn't. We got a Gaia 3 to cross it. And once we crossed it, we realized our fine cross wouldn't kind of follow and advance over it. So we used a Tornus through this entire thing, telescoping Tornus in the three, in the guidezilla, and the tornus then, which navigated over the Gaia third, changed it for a rotawire, and then launched us to do a rotational atherectomy using a 1.5, and then deploying stents to get this final result. The tornus in this kind of case helped us with the passage of the rotawire, setting us up for the next device. In this live case that we did, which was a subtotal case, subtotal RCA, CTO, our wire rather negotiated quite well, but the microcatheter wouldn't in this case. And here we used an ELCA, and with the guides extension into the artery, which helps us center the catheter, also reduces the amount of saline used to clear the blood there. We used a 0.9 fiber, and our typical setup is to use 80 fluents and 80 reps with very slow advancement, with a slow saline infusion to clear the blood off. And you can see the rapid advancement of the catheter. And once that happens, the microcatheter crosses easily, though the IVUS still failed to cross after this. So we then set ourselves up for a rotablator and then completed the case. So in this case, the ELCA facilitated the setting up of a rota device, which gets us largely to the question of getting the rotawire across is the key to a successful procedure in some of these cases. And there are various ways, as enumerated over here, to get a rotawire into the lesion or across the lesion to set us up for a rotablation. A nudged Corsair over the wire balloon, which we used in the past, a tornus as I just showed, and an ELCA 0.9 fiber. And I think these are tools that one needs to have in the cath lab for calcified lesions to even get started sometimes. The imaging catheter does not cross, but the microcatheter crosses successfully. I think our choices kind of expand over here. We kind of get on to either changing it for a rota drive wire or a wiper wire, a rotational atherectomy or an orbital atherectomy. Though we have had a slant towards in favor of rotational atherectomy over the years, there are clearly indications of orbital atherectomy, especially in those high-risk rotablators where the burr is likely to be stuck and stuck. So we have actually kept both these options open for us when the microcatheter crosses. And the idea at this level, when we reach this point, is to circumvent the obstructive layer of calcium, which would then be overcome to enable us to image and then get on to the next level and the next layer of calcium treatment. And here is a simple case. The real target lesion was the mid-LAD lesion. You can see the FFR 0.68. However, what was important was the proximal LAD lesion, though not very tight, was clearly obstructive. And sometimes as we go to the target lesions, proximal to those lesions, there might be calcified areas, which we need to kind of burr and treat to be able to navigate to the site or the index lesion. Here we used a high-speed rotational atherectomy followed by a low-speed, followed by IVUS-guided conclusion of the case. Similarly, in this right coronary artery, we used a 1.5 millimeter burr at a high speed, followed by low speed. And once we did that, the whole idea is to get to this level of imaging, which shows us that there's concentric calcium right in the central image, with a little protruding calcium, which is eccentric in this area with a favorable Y bias. And I think that in this patient, we ended up using a Flexstone 3.5, a 303.5 at that time, and then put in drug-eluting stents and concluded the case. This is the final result. Once we have done this initial task of using rotational atherectomy or any other device, we've now set ourselves up for imaging. The question is, how do we play with the rest of the tools that we have in our cath lab? And here is my little algorithm where I call my first three devices the access devices, which pretty much lets me go and set up an IVUS if possible. And if that IVUS is possible, the IVUS may still not cross, and then I have rotablator and the crown 1.25 to kind of play with. And once that happens, I'm certain that I'm going to have my imaging catheter downstream. The imaging catheter is at this stage tells me whether I'm going to need to upsize the burr, and I'm going to show you a case where I actually go and do that. But if, for the most part, this imaging is going to tell me sizing, and it's going to give me sizes of the various segments of the artery, and I can choose a 1:1 NC balloon to the specific size, go up to high pressure to look for expansion. In the recent years, I have stopped using NC balloon at this stage and gone to a Wolverine directly following in my calcified lesions. Having gone far in this step, I think the next step is image-guided test for expansion. And I think here imaging is optional once you've got this point. But once you get to that point, I think fluoroscopic-based expansion of your balloons is important, whatever balloon you might use. And if it is complete, one may proceed to a drug-eluting stent implantation. But if there is expansion which is incomplete in one view, when you check in two orthogonal views, I think we need to review the calcium morphology at the site of the incomplete expansion. And in my cath lab, I keep it extremely simple. I divide it into two groups, the more than 180 degrees and the less than 180 degree calcium that is there. And next few cases, just kind of give you what has happened and transpired over the years in my cath lab. So once we have the atherectomy and we gain access into the artery, as I mentioned, my first step is to do an image-based NC balloon 1:1, look for incomplete areas of incomplete expansion, and then decide based on these two categories of calcium that I see, whether I use an IVL shockwave or Wolverine. And then the OPN is always a choice that you can interplay with these balloons at various ways. Since 2021, what we did was, after using the NC balloon, we quickly went in and said, whatever the type of calcium we might see, we might use the Wolverine, because it was our experience that a large part of these concentric calciums yielded to high pressure dilatations with the Wolverine as well. And I think, and if at all we still saw in expansion, then we had these choices which we could play with. In recent times, what we do now is we get an image-based sizing of the Wolverine, and that is probably the first balloon I go to at 18, slowly going up to 18. And this is important, 1:1 size to the lumen and slow migration to 18. And if it works, fine. But in a concentric calcium, if it doesn't work, IVL shockwave is the next step. And if it is eccentric, then probably OPN is my first choice. But at many times we've interplayed, and I think this is you could kind of well play between. And I think cost comes as a big factor into what you choose first. Having said that, let me go through some of the cases that have represented this thought process. This is an 85-year-old lady who came with unstable angina, and you can see this heavily calcified lesion in the ostium of the LAD involving a large part of that, a very large left main. There's plaque extending into that area. And our first, the right coronary artery is fairly normal. Our first step is the IVUS catheter, which wouldn't go beyond this one point. So we image whatever's there. And once that happens, I think our choices are, what do we do? An undersized balloon, LCA, rota, any other choice. However, a microcatheter passed. And because the microcatheter passed, it was a great idea to set up for a rotablator. So once we did that, we do multiple runs of rotablator to get a clear run across the lesion with no drop in revolutions or no change in the pitch. And we did 6 runs of high-speed rotational atherectomy extending from 190,000 to 200,000. We almost always follow it up with 2 runs of low-speed rotational atherectomy at 125,000. You can see that. And once we do that, I think we get on to the imaging. You can see, I'm not going to go through the entire run, but you can see the longitudinal view shows a long length of calcified lesion in this segment. The question is, what do you use next? Do we upsize the rotabird? Do we do an NC, Wolverine, or any other? And for that, I think it's important to realize that the decision to use a rota, LCA, or orbital atherectomy may not be an image-based decision in most cases, because you pick it up for an uncrossable lesion, which is not defined by imaging. And therefore, once we have the imaging catheter in, I think these were the images that we saw. And we quickly kind of analyzed these images. And these last 4 images, the E, F, G, H images, had a favorable Y bias. And it would favor an upsizing rotabird. And if I went to a 1.75, I would have a clear advantage. But if I look at the images at C and D, then I think what it tells me is an unfavorable Y bias C and D with more than 180 degrees of calcium and might require an IVL shockwave. So with these kind of images, my next choice here was to use it per my algorithm to see if Wolverine would do the trick. And so what is interesting about the Wolverine is that through the length of that proximal LAD in the distal half, the Wolverine expanded very well. And it defined a very specific area in the proximal LAD, which was not expansile at 18 atmospheres. And so it prompted me to think that, okay, this is the area where I need to deliver most of my pulses. So we chose based on that, I think once we do the Wolverine, we repeat our IVUS. And compared to the first run, post-Wolverine run, you can see that it's a tad bit better, but not a whole lot. And I think we need to now think of the next technology, which is going to be IVL in this circumstances, and 4.0, because right, it's at the ostium of a very large LAD. Based on that, this IVL, we put in 80 pulses. We delivered 80 pulses at 4 atmospheres with the new C2 balloon. Seems well expanded in all orthogonal views. And let's look at the IVUS. And the IVUS says that all these areas which are not touched with the rotablator or with the Wolverine are now show a lot many cracks, better MLAs with good, at least a 30 to 40% increase in the lumen area. And I think this is a good lesion prep, and it favors the positioning of a stent deployment at this stage. IVUS can be used to measure the length of the stent required. In this case, we chose a 4038 DES and covered it, and this is the result we got. And of course, optimization, we know that they were well opposed. The MSAs were optimal to 80 to 90% of what was the targeted MSAs, and the edges were optimal with the flow being TIMI 3. When do we upsize a burr? In a heavily calcified lesion such as this, you can see we went on with a rotational atherectomy using a 1.5 burr, like in most cases. And when we find images like this, where we have calcium eccentrically placed with a wire favorably biased and actually sitting in the belly of that calcium, then we know for sure that upsizing the burr is going to make this better and is going to make our dependence on other devices lower to that extent. And I think in this case, we went up with a 1.75 burr. And this was the image before and after rotational atherectomy. We had set ourselves up for a cutting balloon and then 2 stents with a balloon dilatation of the diagonal. And this was our end result. And this patient did well for a long time post this case. We had excellent MSAs. So here we used a strategy of a rotablator with an upsizing burr, used a flextome and a DS. The decision to use, as I mentioned, was the initial use of rotablator is not image-based, but the escalation of burr size or the transfer to an orbital atherectomy sometimes is often based on imaging inputs and lesions that continue to be difficult to cross sometimes. Now, when we look at cases with this moderate circumflex and LAD, you can see this very tight lesion in the circumflex, and the IVUS does not cross here. This is classically 2 S-bends, a difficult case for rotablator and a chance of a little stuck burr. Orbital atherectomy becomes an automatic choice. It has the advantage of, ablating antegradally and retrogradely on both ways. And then once we do that, the images tell us the story of the size, the length, and of course, that ring of calcium, which is now 2.68 in diameter. And the question again, Wolverine, and if it shows in expansion, IVL. This is exactly what we did. And you can see that the Wolverine fails to expand at 18 atmospheres. And when it does, the IVL balloon goes and does the trick. And this has been a consistent pattern for us. And this is the final result for that artery. Here we used an orbital atherectomy, Wolverine followed by IVL shockwave and a DES. In this case, which is a 63-year-old gentleman who had an acute coronary syndrome, where we fixed the RCA 4 weeks prior to this procedure, brought him for a stage PCI to the LAD diagonal. It's a calcified bifurcation lesion. However, the IVUS catheter crossed easily. And when the IVUS catheter crossed easily, I think it was important for us to kind of peel down to what was the area of that calcified area. And we found that there was a dense calcified area just around the branch, as you can see. And here, I think we could either use we could go ahead with the Wolverine as well. But what we chose to do in this patient was we chose to do an orbital atherectomy. And once we'd done that, we realized that we'd shaved off a part of the calcium. And that's evident by the increase in the MLA at that site. from 3.34 to 3.9. And once we thinned out the calcium, it was easy for the Wolverine to do the job. And we did a Wolverine with a DB in the diagonal, and the Wolverine followed by DS in the LAD with a great bifurcation result. On a similar theme, I think when we have these similar cases, it just goes to show our thought process. For the circumflex, the IVUS catheter passed in easily, and so our choices between all these two per algorithm would have been was the Wolverine, and you can see that distally in the lesion, the Wolverine cracked it very well and expanded well. Proximally at 18 did not. And this tells us the story repeatedly that the calcium had not budged with the high pressure Wolverine dilatation, where you can see cracked calcium distally. So that's the place for the IVL shockwave in our cath lab, again, which cracks calcium. And I know that the circumflex is now ready for DS implantation. The question is whether we need to bring it all the way to the ostium. And this image then tells me that I would have to bring up my stent all the way to the ostium of the circumflex. Having said that, we then entered into the LAD, and now the choices were we could have entered sub-strut or we could have gone within the struts. The question is we would have to convert it either into a DK crush or a Q-lot, and here is where imaging matters. And when we look at these images, we can see that clearly the wire has entered through the struts, and so our options are now to convert this into a Q-lot. And so we put in a small balloon to separate the struts out. The IVUS catheter in the LAD again failed to cross the tight lesion, so we pulled out our orbital atherectomy again. And once we did that, once we did the orbital atherectomy, we had a good run of the IVUS. And again, the images gave us the same story. It defined the areas of calcium. Here we went and did an orbital atherectomy into the diagonal branch, followed it with a cutting balloon, and then put in a drug-eluting balloon, as you can see. And for the LAD, we went in with a orbital atherectomy, followed by a Wolverine cutting balloon, 1:1 size at 18, and then followed it with a DES and completed the case. And I think this is post-Wolverine, the IVUS. You can see that these rings of calcium, sometime with an atherectomy followed by a cutting balloon at a high pressure, can do an immense job by cracking calcium in multiple segments, making it expansile. It looks like the lesion was prepped well. A good time to spare a few, we spared a few pulses, and this is the LAD again. This is the final result with what was the orbital atherectomy of Wolverine and the DS in the left main to LAD. Calcium and thrombus kind of pose a kind of a sticky problem with a slow flow, and when you have this elderly man with this kind of a looking lesion with TROPS I which are raised, IVUS doesn't go. I think our tool to go to now is the excimer laser. And here we did the excimer laser with contrast because with saline, the laser would not advance. And often when we've done that very sparingly, but whenever we've done that with caution, because perforation is a big risk sometimes, you can see that there's that defined calcium right in the longitudinal view. And this is well seen on the IVUS. And when we look at these images closely, you can see that this is the attenuated plaque. And these are the plaques which are at high risk for slow flow with rotational atherectomy. Attenuated plaque being that you do not see any intimal reflection, and all this is thrombus plus a porridge of cholesterol. And actually, these fibrocalcific plaques respond extremely well to Wolverines. And so we set ourselves up to doing a Wolverine. We also look at the septal branch in these, and can you see the slow flow in the septal? I'm extremely sensitive to these, and I would chase these to make sure I don't lose a septal. Some of our septal closures have been associated with late complete heart blocks at day 3 and day 4. And I think it's best avoided by this little one move and keep it patent through the stent procedure. And then these patients do well. There is a lot more, but I think I'm running out of time, Raj. So what I'm going to do is I'm going to go straight away to some of my, some of the last areas where I think I'm going to show this slide, which says that basically what we really need to do with imaging in these calcified lesions is we need to determine endpoints by doing the various measurements before like in this case, this is a 3O artery, so we have a reference area of 7.1 and 9.5 in the proximal segment. And this helps us size the stents, basically, and it could be anything 3O, 3.5, and whatever length. What is important is that we divide this entire stent length into various segments of the artery, which would have target areas which are different, with 7.1 here and 9.5. And if we find target areas which are less than 7.5, less than 80% of the expected MSAs, then I think that we are underexpanded and we need to make our best to expand it. But this should be done within the boundaries of safety with high pressure balloon dilatations. And in my calcified lesions, my IVUS guided approach, the lessons that I've learned is that IVUS catheter non-crossing is a pointer to rotational atherectomy. Images subsequently helped me choose the correct device beyond rotational atherectomy or orbital atherectomy for optimal preparation of lesion, bearing in mind the cost and the effectiveness of the tool and trying to abbreviate the procedure as much as possible. While the Wolverine worked in a few cases, in a lot more cases with circumferential calcium, IVL is an important and essential tool in this subset. And we need to have all our tools available to us when we get into these calcified lesions. And a multi-layered approach with various combinations and order of devices used is a reality, no two lesions being alike. Thank you very much.
Thank you so much, Kirti, for that incredible talk. I think it covered a very wide array of possibilities in calcified lesion. Thank you so much for taking on some of the very complex areas within the calcified lesions. In fact, there are several new devices now in development. There's one particular company that comes to mind. It's called FastWave. They're developing a technology where a laser fiber is actually going to be put inside the balloon. And this balloon that you would deliver then and would really provide an unlimited amount of laser pulses to the area to break the calcium. Let's take a couple of questions here from online. How safe it is to use Wolverine in a thrombus containing lesion?
In fact, quite safe actually. It's better than most of the other balloons because it works in that milieu of fibrotic lesions as well as calcified lesions at the level of at the level of contact where the blade meets the lesion. Actually, the pressure is almost 3x. Like, for example, you take it to 12 atmospheres and you give it 36 atmosphere pressure at the level of the blades. So it's an extremely effective balloon. You avoid that ping-ponging or the watermelon seeding effect. And when there is visible thrombus, it's almost always best to rid the thrombus before you put any device, lest you fear dislodgement of thrombus distally or proximal migration. So that's a key to any intervention, though.
Another question is how safe it is to do rotational atherectomy in an acute MI?
So, I mean, we have from 2007 to now, we've actually put down our cases and we're hoping that we'll write it up in a paper one day. We've got around 35 cases of ST elevation myocardial infarction with rotational atherectomy. And I think these are classically the elderly 85, 80 plus patients where there's a very large plaque burden. Much of it is calcified and the thrombus burden is very, very less. I would fail to take any device in like a thromboaspiration on any of those devices. But today, if I have to do these cases today, then my first device for these kind of cases is the excimer laser, which gets rid of the thrombotic component. And then a few minutes later, I think it sets me up for a rotational atherectomy. And we've got a few cases now. And I'm hoping that with this strategy, our slow flow rates and our CKMB climbs or the damage during the procedure is going to be minimized.
So for excimer laser, Kirti, do you go with a 0.9 at 80-80?
So the only fiber that we use for acute coronary syndromes in de novo lesions is a 1.9 fiber, and we've tried various energies, and we have stopped using anything less than 80/80. We use it with saline flush, with a saline flush. Almost always try to get a guide extension catheter close to the proximal index lesion so that the saline flush is effective, and we use a 1.4 fiber only in the left main, and in ISRs where we need to deliver a little more energy, because the cumulative energy delivered by a 1.4 by sheer the amount of fibers there are is more than a 0.9 for every second or every run that you kind of exert in that lesion.
Dr. Harris from Malaysia is pretty much talking about the same point that we've been discussing. Would you consider removing thrombus first prior to ballooning or rhoda?
We always do that. I mean, there's no question that we should try and remove it, either using a Lexima laser has come to our rescue, or sometimes it's a simple thing. Just do a simple balloon dilatation, get some flow in. For people who don't have these devices, put them on a heparin infusion and get them 2 days later to do the rotational atherectomy, where much of the thrombus is cleared up a little bit.
One last question we'll take, and then we'll move on. What is your device of choice for debulking eruptive calcified nodule?
I think we could use, eruptive calcified nodule once you recognize. I try not to get myself into that space of trying to decipher whether it's eruptive or it's a protruding big block of calcium, which is non-eruptive, because the behavior is going to be different and it'll then tell me. But whatever the calcified area, I think you need to look at crossability and expansibility. If it doesn't cross, you'll have to use your ablative technologies, one or the other, to kind of ablate and make space and room for your other technologies to go in. And once you've created space, the order of device is going to be Wolverine in my cath lab, followed by whatever other that needs to, within the boundaries of safety, to get the best MSA.
No, that's great. Thank you very much, Kirti. There's quite a few other questions, but I'm going to have to move on. I'm going to try to answer some of them online. Really appreciate it. Great talk. Lots of excitement. Very important topic. And we look forward to having you again on this forum.
Thank you so much, Raj. And thanks a lot for this patient listening, all of you.
Thank you. So let's continue with our program. Our next segment is Journal Watch, and Journal Watch is always done by Dr. George Vetrovec. He's a emeritus professor of medicine at VCU. His experience covers 4 decades of interventional cardiology, and his research has focused on optimal management of ischemic heart disease involving high-risk PCI, reduced left ventricular systolic function. He really is a trailblazer in interventional cardiology, and it's an honor and privilege to have him every time to talk about the latest science that is noteworthy in interventional and general cardiology both. So I'm turning over to Dr. Vetrovec.
Thank you, Raj. I'm trying to share my screen now. Let's see.
We can see that. We can see your screen. Yes.
All right, great. So we're gonna, I call this journal notes, Raj, just because I didn't want it to conflict with any other branded discussions. So let's see. Somehow my slides aren't going forward. There we go. I just want to assure everyone I have searched as much as I could to get this information and studied it at great length. So the first, we're going to present 3 recent articles. The first one I thought would be very pertinent is a publication that appeared in JACC And it's got a headlining sort of group of investigators, the usual group, Roxana Moran, Greg Stone, Deepak Bhatt, Gary Mentz. It's a highlight group. And they published a paper on the comparison of intravascular imaging, functional or angiographic guided coronary intervention. That is, do you image the plaque? Is that the best way to go? Do you measure FFR basically or flow, or do you just use good old angiography? And their goal was to pick the best one of all of these choices. They did a so-called network meta-analysis of randomized trials comparing image-guided or functionally guided or angiographically guided PCI. And the primary outcome was a composite of MACE events, which they included CV death, MI, and target vessel revascularization, target lesion revascularization. And the PCI methods were ranked best to worst. So they looked at 32 trials, 22,000 plus patients, and they compared these outcomes and compared the different strategies. And when they looked at it, the compared to angiography, functional imaging guided PCI was provided lower MACE and MI. The results were consistent for both ACS and non-ACS patients, which is always one of the questions. Is there something you learn in the ACS patients? So compared to angiography, the functional imaging and the intravascular imaging were both better, with intravascular imaging being somewhat better. This is sort of the central illustration here. And if you look at the left, the easiest one to look at is the so-called MACE here. And you see it stacks up in terms of first guided strategy is better. And you see the least is functional guided PCI, and then best is the intravascular imaging. And there's a little splay with individual components of this as you go across, but in general, intravascular imaging wins consistently. So in summary, CV events were most effectively reduced with the use of intravascular imaging guided PCI. Least effective at reducing CV events was angiographically guided PCI compared with intravascular imaging guided and functionally guided PCI. And so this goes back to the issue that we've all been struggling with. I think we've been hearing this in various forms, maybe not as rich in terms of numbers of studies, and particularly comparing two other modalities to angiography. And as you know, there's only about a 10% uptake. The editorial for this article was written by Cindy Grines and Allison DuPont. And I'll just take there and quote their conclusion. And conclusion is increasingly clear that at both advanced intravascular imaging and hemodynamics are very important during diagnostic angiography and stenting. We strongly believe guidelines should be updated to reflect the additional data available. So I'm going to throw this open to see if there are questions, comments about that. Raj?
Yeah, so there is a question that has come up already. Is iLumen 3 was recently presented at TCT or one of those interventional meetings, and it did not show benefit of OCT guided intervention. How do you take that one trial that's an outlier with a very aggressive protocol and put it in a context of this science?
Well, I obviously don't have all the answers. I would propose the following. OCT provides very interesting information, but I'm not sure it's quite the same information that one gets from IVUS, and I think that may be one of the one of the issues. And so it may have something to do with the optimum methodology for what you want to know. And so that may be one explanation. It may be that overall the OCT has had a lot less experience in general, although the people in that investigation were experienced. I think if it's out in the on the general use, it probably has less experience. But I think it's probably that it's measuring something a little bit different overall.
Yeah, I definitely think that there is a learning curve with the OCT. In our lab, we use a lot of OCT, and we have gotten very good at it. But I can see how in the early stages of it that you have a potential for undersizing the stent with OCT, because it's certainly in IVUS, how we take media to media diameter in OCT. If you take media to media, which sometimes is difficult to do, you very much oversize that. If you go by lumen, you may undersize it. The new machine with a high definition OCT from Genuity and Nipro in Japan that we are using now, has improved our ability to image some of the very tight lesions because the catheter size is so much smaller than the traditional Abbott vascular platform. But Abbott vascular platform has an advantage that they have a tremendous software. So every thing is so automated, it's so quick to get MSA, stent expansion, etc. But I think that this is a great paper, and clearly this is the newest CMS reimbursement guidelines that came out this year, for at least for ambulatory surgery centers. FFR, IFR, IVUS, and OCT all are reimbursed for first time in US as an individual code outside of a DRG payment. So DRG payment applies to the hospital, but in ASC, CMS is recognized now that these technologies are important. So I think it's a great paper and a great comment on editorial.
Yeah, when you talk about it, I think this is an area too that as AI gets stronger and stronger, this is going to be one that's going to make the time involved in the assessment of imaging and even the experience of the operators in imaging, where it will be more automatic than requiring expertise on the part of the individual. And I think that'll make this all easier.
That's great. What's the next one?
All right, let's go ahead now and see if we can do it. This one's interesting and probably provocative a little bit. This is the viability and outcomes with revascularization or medical therapy in ischemic ventricular dysfunction, the pre-specified secondary analysis of the revived BCIS-2 trial by Dr. Pereira. And
I don't see your slides.
I'm not quite sure why I don't have them.
If you can share your screen one more time.
Okay, let me see how I do that. Okay.
At the very bottom of the screen, it says...
Yeah, I know where that is, but I had to get out of my thing so I can get there. Did that do it?
Yep, that did do it.
All right, let me get it to full screen.
Bigify.
There we go. So this is certainly controversial. Everybody understands that after long years, the Stitch trial showed that revascularization improved outcomes, but it didn't show, and to everyone's amazement, it didn't show that there was clearly a correlation between viability and that improvement. And a lot of us joke and say, viability is used by the surgeons when they don't want to do a case. But the reality is that this is been something we've never understood. We think that if you revascularize hibernating myocardium, it ought to come back to function, and that ought to be it. In reality, there are other explanations for it. It may be that if you provide good flow to the remaining vessels, or the ones that are occluded, so that you have better overall revascularization of the myocardium, it may well be that that's what protects you from future events. And that's why patients do better. And it has nothing to do with improving LV function or improving, correlating it with the extent of myocardial flow. So they looked at it in the Revive study, which was one that looked at revascularization. Now, there have been a lot of criticisms of this study because it didn't necessarily have as extensive ischemic disease, and it didn't have maybe it's a little unclear as how extensive the revascularization was. This shows how complicated it was of all the different therapies, different techniques that were used for assessing viability. So there's PET and there's echo or sonography, there's SPEC, CMR, there's everything in there, which I think is always a real challenge for this. But the bottom line is, when you look here at the primary outcome in terms of viable myocardium, it didn't predict outcome. It didn't predict all-cause death, as you see here. It didn't produce improve cardiovascular death. It didn't improve hospitalization, borderline for heart failure, and left ventricular function didn't significantly improve. And then if you look at non-viable myocardium, improved left ventricular function was less likely and predicted more adverse outcome, as did SCAR. So it certainly didn't do anything to further the idea that revascularization improves outcome. But again, there's the whole issue of how well they were revascularized and how extensive the ischemia was. I thought it was interesting. There were two editorials, not one, that were written or included with this paper. The first one was Julio Panza, who's sort of a believer, and he says his final conclusion is, however, a more thorough understanding of the interplay between the mechanism of benefit and the therapeutic goals of revascularization indicates that the assessment of myocardial viability still holds a place in the diagnostic evaluation of usually complex clinical scenarios to reach the best treatment decision for each patient. The other editorial, written by Udelson, Fonarow, and Banau, talks about realigning priorities in the evaluation and management of patients with heart failure. And their statement is in the absence of an acute coronary syndrome, in which case revascularization might be affecting so-called stunning, assessment for underlying ischemic heart disease can occur at a later time or in a way or by a modality that will not interfere with the aggressive use of guideline directed medical therapy. They are believers that the real lifesaver here is the medical therapy, not the revascularization. So I think this is an interesting paper. Obviously creates a lot of continued controversy about this, and open it up for any discussions. Raj?
Yeah, so there is one question here from India. And in India, in the assessments of myocardial viability by CMR or PET scanning is fairly rare because of not having a frequent availability of such a high cost technology. So, but they don't base their PCI decision on those viability studies. They look at an echocardiography frequently. And perhaps, this, validates a more simplified approach, that we don't need to be so fancy in making a PCI decision. And it maybe has something to do with, in my opinion, with probably related to the complexity of intervention, that can it be safely be done? If it can safely be done, then trying to prove that the intervention is absolutely necessary may not be necessary, and just do the PCI and a guideline-directed medical therapy and hope for the best. What do you think?
I personally think that it's a complicated issue, and I think some of these patients get better, particularly if they have very active ongoing ischemia. Some of them have just chronic, poor flow to a region, but it's not infarcted. And I think what you're doing there is, by improving overall flow to the myocardium, you protect the heart better if they have an event. And so they're likely to do better. So I think it's complicated, and probably the mechanisms vary from patient to patient. I do think complete revascularization, to the extent that can be safely done, and you can even look at the ischemia trial, there's a indication that it may improve functional ability and maybe later events, reduce later events with the subtraction of the initial risk. So I think it's the thing to do, but whether the imaging is important, I'm sort of like you. I think it's more important to do to the treatment.
Great. There are a couple other questions, but let's move on to the next one.
All right, this one will be
given that
quick,
this is
Raj.
so controversial.
Yeah, I thought this was very interesting. I grew up in interventional cardiology, general cardiology, believing that you could have severe aortic stenosis, but as long as you didn't have chest pain, heart failure, ischemia, so forth, you were fine. You just waited for this some sentinel event to drive this. But the fact is, this has been changing. There's been more and more comments and data that suggest that you don't have to have symptoms to be at risk. So this is a large evaluation of, almost 600,000 patients looking at echocardiograms. This is, again, has a star-studded cast of people involved in it. And the real goal was to assess mortality rates for all degrees of aortic stenosis severity. So you see here that 88% of patients didn't have any aortic stenosis. There was mild to moderate, moderate to severe aortic stenosis, and severe aortic stenosis. And they look at the outcomes, and this pretty clearly puts it there. You see mild aortic stenosis for your treatment rates was 1%, but the 4-year mortality without AVR was 25%. This is mild aortic stenosis. And you can keep going. And when you get to severe aortic stenosis, the 4-year mortality without AVR is 45%. And but 60% of those did get treated. But even in that group, which has an almost 50% mortality rate, only less than 2/3 of them got treated. So I think the real issue here, as you look at all of this, is, and this looks here at the 4-year mortality rates. If you look at the adjusted ones for other various conflicting issues, you see that, again, severe aortic stenosis has a 4-year mortality untreated of 42%. And on the right-hand side looks at the mortality rates just plotted here for the at-risk population. So the real question is these patients have a high mortality rate. How do we figure out who should be treated, and are we not doing enough to identify patients who will really benefit, and do we know which ones are the severe ones or the less severe ones are going to benefit with earlier AVR? So there's a lot of study that can be done here, but at least for people at risk, I think this is a real potential impact for improving outcomes for patients by not waiting till they get too far along. The real stress right now is to figure out who will benefit by this earlier treatment. And again, you're playing off the longevity of the valves and so forth. I'll just end this with the editorial for this was written by Eugene Brunwald. It's entitled Aortic Stenosis, a 6-Decade Odyssey. And there is a graph from a paper that he published in 1968 with Richard Ross, and looking at that sudden onset of symptoms and the sudden drop off in terms of death, which is the basis for what I learned and we all practiced for quite a long time. So he talks about how it's evolving and how the importance now is to pick the right time. So I think this is really an interesting evolution. It's a real opportunity for those of us who are interested in this particular area. Raj?
Since I don't know, a lot of people know, but I did the first commercial Edwards tower in US in 2011. Since I've been doing the tower procedures, and the tower procedure is so simplified now, and it's so standardized that I feel that our threshold for treating these patients have really reduced a lot. Because dyspnea exertion is one of the very common symptoms that we encounter in our clinical practice. And, patients might come and say, well, we have shortness of breath for a long time. It's not really changed. The aortic stenosis is less than 1 centimeter square. I tend to treat those patients now than what I used to do in my previous clinical practice before TAVR, when the only option I had was to send patient for an operation. So I think that has changed our thinking, and I think that some of that has probably that knowledge on the TAVR procedure has probably affected this decision making. I do, however, think that a word of caution is the durability of these TAVR valves in a low risk patient population who is younger, because I do see some concern with the long-term durability of some of these valves. So I think that's an issue. But I think that the idea is great. Any other panel members have any other comments?
Yeah, I do, Raj. But
Yeah.
I would have to say that it's interesting. This sort of ties together Dr. Desai's earlier talk with this one, because now in both cases we have an expanded toolbox, right? So we could never discuss having an LDL of 55 or less until we had tools to get us there. We could never discuss the possibility of an earlier intervention until we had TAVR to get us there. And in fact, there's discussion and strategies about now how to really handle, just as you pointed out, the valves have a limited durability. And so the question is really, how are we going to handle the third intervention on this patient population? So instead of thinking about maybe putting in a surgical valve while the patient is younger, now we're thinking about putting in a TAVR and doing the surgery as the second intervention and the TAVR as the third intervention. This is fascinating stuff, but you're right. It's going to change our thought process and continue to change our thought process.
Yeah, I really think that I always remember a patient I saw early in my career who had congenital aortic stenosis, and he was in his 20s, and he had a gradient of 150 millimeters across his valve, but he had very minimal symptoms, and he was a competitive baseball player. And we replaced his valve, and he didn't think he was symptomatic because it had been the way he had lived. And I think these come on very slowly sometimes, and patients don't realize it. And I've always joked that he was stretching his doubles into triples after he got his valve replaced.
I had a similar case of a guy who his valve area was like 0.4 and came in and swore up and down that he had no symptoms whatsoever, didn't want to have an intervention. I wanted to follow the guy home, you know, and check into his house because I thought he was lying.
That's funny. All right, Raj, I hope that was
Well,
helpful.
great. Thank you. That was fantastic, George, as always. Let's continue to move on with the program. Now it's my honor and privilege to introduce Dr. Brian Cluck, who's a senior interventional cardiologist, now part of my practice at Cardiovascular Experts of Pennsylvania in Pennsylvania, also course co-director of C3 program. We have a very, very interesting topic for Brian. He's going to talk about nickel allergy in interventional cardiology. I know that we don't, talk a lot about this, but Brian and I've been thinking and digging through a lot of new information, and I'd love to have Brian now talk about nickel allergy and what do you do about it.
Can you see my screen?
Yes, I do.
Wonderful. That was what I was hoping for.
Yeah.
So now we got it?
Yep. We see.
Terrific. So yeah, this is a very interesting topic and one that I think many people know about in some sense or another, but not a lot. I am currently preparing an article that is going hopefully for publication. And my goal in life actually is to have it published and then have Dr. Vetrovic review it in the journal notes in upcoming presentations. That is certainly anybody's goal. So this is an interesting case. I'm not sure. So this is a 45-year-old lady. She originally was Pennsylvania, our area. She's currently living in North Carolina, and she presents to our office kind of virtually to discuss an alternative PFO closure a procedure, suture-based, which I'm working to get going in Harrisburg, and I had done a fair amount of in my previous life. This woman in August of 2022 had a hospitalization for some visual disturbances. She had dysarthria. She had a numb right arm and face. Her CT and MRI were inconclusive. She had an echo and a TEE, which demonstrated a PFO and an atrial septal aneurysm. She had a grade 3 shunt by TEE and by TCD bubble study. Where's my change here? Her monitor showed no evidence of atrial fibrillation, any atrial or ventricular arrhythmias. She was placed on dual antiplatelet therapy with aspirin and clopidogrel. She had nickel sensitivity by history, and she had a patch test done, and she had a strongly positive nickel allergy. Her case presentation, past medical history, is rather long-standing. She had hospitalization for stroke symptoms about 23 years prior, shortly after commencing oral or birth control pills. She had a diagnosis at that time, which was complex migraine. She's gravida 3, para 3, and a very complex history during her third delivery. About a week postpartum, she had chest pain, she had elevated troponin, she had a cath, and at that time she had no coronary obstruction. She had an apical wall motion abnormality, which was rather mild. About a week later, she presented once again with a full-blown STEMI. She had VF, she had cath, she had 2 vessels, so-called SCAD, and no major change in her ejection function. She had no further chest pain over the years. She had serial echoes, which normalized. And again, she presented for a virtual opinion. We did a very, very long and thorough discussion, literature-based discussion on nickel reaction following device closure and PFO. We discussed alternative strategies, including PFO closure using a suture device. This device is, and with all forgiveness for this, FDA approval is actually for cardiovascular closure, but it's not FDA approved specifically for PFO closure. There's an ongoing trial called the STITCH trial, which is hopefully going to answer that, but it is available in the United States as well as fully available in Europe. There are very few number of people that are doing this procedure in the United States. So in spite of my long discussion on 12/8 of 2022, she listened to her local cardiologist. She had PFO closure in North Carolina with an Amplatzer device, and not only an Amplatzer device, she had an Amplatzer cribriform device placed. She had, within days after the procedure, she had chest pain, she had chest heaviness, and breathlessness post-discharge. And after going over these symptoms with her cardiology panel, they referred her to an allergist. She was unresponsive to Benadryl, and she had prednisone 40 milligrams per day. Her symptoms improved over the course of the last several months, but returned on taper, and the allergist recommended a explantation. She saw then a second allergist, based on her unresponsiveness to his prednisone and Zyrtec combination, she was then at the step of either having the addition of methotrexate or explantation, and she favored the latter. She had her explant performed on 10/23/2023 at the University of North Carolina in Chapel Hill. She had a cardiac cath that was preoperatively performed. And her cardiologist attending as she entered the hospital in Chapel Hill said that this could not be an allergy, and the absence of rash and chest pain and dyspnea signaled a mechanical issue and was not related to the device. Her symptoms resolved completely at the removal of the device. So just to kind of review here, nitinol, it's an alloy of 45% nickel, 55% titanium, and is the most commonly used device in metal in occluders. It has high durability, it's corrosion resistant, it's very malleable, and it's ideal for household goods, aerospace parts, medical devices. In the general population, its prevalence is about 30%. With the highest prevalence of in the demographic of women less than 30 years old. The rate of nickel allergies is increasing in recent years, likely because of the rise in body piercings and the lack of legislative restrictions in nickel in a variety of clothing and jewelry, et cetera. And this is a typical place to look for or ask about nickel, because many of the snaps on jeans and belt buckles are made of this component. Such that there is now the device syndrome, which is hypersensitivity and metal reactions, and it has been described previously. It appears to be predominantly a delayed T cell type reaction to the metal ions. This process may be mediated by cytokines, including the usual actors, interleukin 1B, interleukin 6, and TNFA. The clinical manifestations, very interestingly, are mostly a headache, palpitations, shortness of breath, chest pain, urticarial rash, pericardial effusion, and angioedema. And the strategies to mitigate have included load up, in this case, high-dose steroids, dual antiplatelet therapy. But it seems as though explantation is something that works fairly well. Back in 2006, at the identification of a migraine paradox with PFO closure. As most of us know, migraineurs get significant improvement by and large from PFO closure, but there are a small number of patients that experience new or worsening migraine headache following the device implantation. In this particular study, it was all Amplatzer, but that, if you look at the date, that's likely because of the approval trajectory. This study followed 108 patients over a 5-year period, and they studied patients who had experienced chest pain or new increased migraine headache. Nickel patch testing was, in this case, mostly available on these patients. And the interesting finding was in those patients with a combination of chest pain, palpitations, migraine headache with aura, there was a significantly increased risk of these symptoms in those patients that had a positive nickel test. And then if you go down to the dual chest pain and migraine headache, or just new or worsening headache, all of those were significant. This is kind of what patch testing looks like. There are in the United States 2 available patches, 0.25 and 0.5 strength, with, as you might expect, a little bit more sensitivity with the higher dose. But importantly, it is not 100%, so you can't guarantee that a patient is going to react to a device. It's about 80% sensitive, even at the high dose. Various devices have handled this in terms of their patient information. The Watchman is, I think, a little bit more forward thinking about this. This is their patients who have an allergy or sensitivity to nitinol, nickel, or titanium. Titanium is largely inert, but nickel in particular. This would be patients who should not be considered. If you look at the Amplatzer patient information, it is nowhere near as informative. And I think that's one of the things that I'm hoping to get out of this presentation here. This is the normal way that nickel elutes, but there are people who have reactions for a long time afterward. And perhaps the sentinel discussion on this comes out of Utah. This particular group had an inordinately high number of patients in one place who had device implantation, and it gave us a unique opportunity to sort of follow patients over a long period of time while a high number of PFO devices were placed. And they had 58 patients who had device explant over a 10-year period for symptoms and a positive nickel test. The mean age was 42 with a free male preponderance. The symptoms included fatigue, headache, chest pain, and palpitations. Importantly, it did not include rash. The mean explant time, I believe this may change over the years, but was 8 years of rather severe symptoms for these patients. It involved both devices, and all patients had significant improvement, and 42% of these patients had complete resolution of their symptoms. These are the symptoms after the device placement. Again, chest pain, headache, and a smattering of other things, but you'll notice that rash really doesn't appear anywhere on the list. Patch testing evaluation for hypersensitivity out of the Contact Dermatitis Society does not recommend testing everybody. It recommends testing people with a self-reported history of metal reaction. And again, positive metal test does not necessarily prove symptom causality, but it certainly is a helpful thing to have when you make a decision about implanting a device. And then just to bring out the fact, much like there are strategies for lowering our LDL cholesterol that we didn't have years ago, lowering our bar for TAVR with new or for aortic stenosis with newer technologies. The Noble Stitch PFO closure device is something that is now available. It is not widely available as there are a limited number of practitioners performing it, and it is a rather new technology. And what I was hoping to get out of this is enough of an interest that Raj would invite me back to talk about Noble Stitch separately, but I'm not going to do that in any more detail here. I'm hoping to bring people's attention to this topic and get some interesting discussion. My take-home points for this are that nickel sensitivity, while uncommon, occurs and has been reported with both FDA-approved devices. And I might add that when we're talking about peripheral vascular intervention and even coronary vascular intervention, nitinol and nickel is involved in a number of our devices, and this doesn't only apply to PFO closure devices, but other devices as well. The most common symptom is not rash, but rather a constellation of chest pain, dyspnea, and migraine headache. Awareness of this device syndrome is limited, and while treatment with dual antiplatelet therapy, corticosteroids, immunosuppressants may improve symptoms, explantation definitely demonstrates clinical improvement and is something that is necessary to consider in patients with long-standing symptoms. Nickel patch testing may provide a pre-procedure strategy to identify these patients before device implantation. Novel non-device strategy to close defects may, and in some cases, should be considered. I would add one extra take-home point that I thought of after I made this slide, and that is that, in addition, the devices have varying degrees of nickel content. So an Amplatzer is a very tried and true device, but thousands and probably 100,000 implants over the course of the last 2 decades or so that it's been available. But it is highly nickel content. If you look at a Gore device, it has much less nickel content. And even among Amplatzer devices, there are devices that have less of a device signature. And those things should all be considered as things to do moving forward in these problem patients. But I think awareness of this, in case people are not, is something to keep in mind as they go through their day. And those are my thoughts.
Brian, that's fantastic presentation. So, one of the challenge, and I'm glad that we're talking about this, because I just recently had a patient with coronary disease, and I did tell you about this patient, and she was going to have a heart cath, and right before the heart cath, she told me that she had nickel allergy. So I took a pause from a cath, and actually I taped a stent on her skin, and within just 24 hours, she had a profound reaction on the skin from the stent. And thank God that I did not do this case and put stents in this patient. Luckily, the patient's cath, had moderate disease and did not require a stent, but I had already told her that I would be referring her to bypass surgery should she have blockages. I think that there is industry folks here on the session today, and I think this is a call for the industry to come up with a non-nickel based stent systems. One of the, even a stainless steel bare metal stents have a small percentage of nickel. And it appears, at least, in the United States, where these issues can be tried in a medical legal fashion. I think this is a very important issue now that, we proactively need to ask these patients about nickel allergy, and they probably need some form of testing. And this should be included in the informed consent, because if you implant a device into somebody and then the device had to be explanted, I can, be certain that, that I would be, called by attorneys to do a defense on a case like that.
I think you're 100% right, Raj. I think that there is no one size fits all. There are different devices, but this particular subset of patients, there potentially are other options. You are a little bit more skeptical of Noble Stitch than I am. My experience is different than yours, and you have every right to be skeptical of it. But the way to deal with skepticism is to do clinical trials, have this be available, and compare it both in terms of its success as well as its potential utility in those patients with nickel allergy. But it's
beyond that, though, right? It is beyond PFO, because the nickel is ubiquitous in
precisely.
Precisely.
In these patients, as I said, I think one of the reasons why this isn't necessarily something that came to light until the group in Utah had this high single center volume, it was enough to then raise it to the level beyond onesie twosie case reports, which in fact is where it is beyond that. This isn't just limited to the devices in Utah. It's just that the Utah guys had enough of it to make a publication. But I think that, it's something that you're right, we have to discuss. But also we have to recognize in those patients who come back, whether it's because of a cardiovascular device that's placed or a PFO device that's placed, and recognize that on symptoms that you wouldn't necessarily think are allergic symptoms are in fact allergic symptoms and something to be taken seriously. I can think back to one or two patients in my 20 years of doing PFO closure that came back with a constellation of symptoms. And I did the same thing that doctor in North Carolina did, and took them to catheterization and cardiac, CT scanning, because MRI is not possible with a device. But and at the end of the day, left with a head scratcher that the patients just sort of dealt with for years and years and years. That's not fair to the patient. If we know about this, it's something that we should be able to discuss with them up front, make alternative strategies, and hopefully together with industry, make appropriate devices.
Yeah, so Biotronic has a Orsiro Mission DES. Those who don't know, that has a permanent secondary coating on the stent that prevents 95% of the nickel ionization to the patient, and that was just communicated to me by the industry. It's a benign silicon carbide coating that is bonded to the stent. And I'm sure that there is more, but I really think that we have to have zero nickel devices, in future to address some of these patients. Any other panel members have any comments about this? Because this is really a newly new issue. Is not new, but it's really now being brought to the spotlight, given there has been a multiple reported cases of explantation of interventional devices and severe symptoms, which can be potentially become a medical legal liability at least in United States.
Raj, can I make a question, please? Can you hear me?
Yes, I can hear you now.
Perfect. First of all, I would like to say hello from the freezing Greece. We have really low temperature today in my area. We have a snow. So it's nothing like Greece you probably know. So it's completely different. I'm very happy to see all of you in C3. And I'm very happy to be with you once again. I would like to make a question because this nickel allergy is indeed raising concerns about several things and several devices that you are putting in our patients. I mean, is there any different reaction according to the which vascular place, which vascular bed the device, the nickel device which is going to place? Because we're using these devices, the nickel or nitro devices, in several other areas with a stent, and indeed we never had any problems, or at least we didn't know they have any problems in those patients. So, do you think there's a different reaction when you're using these devices inside the endothelium of the heart rather than the endothelium of the vascular bed? Is there a difference there?
Yeah, I think that's a great that's a great point. But I will tell you that I have had a couple patients with femoral procedures, and I think that Brian knows of one patient, and I know of one patient where a nitinol-based stent system was placed in somebody's SFA. And almost perfect implantation with IVERS guidance, proper post-dilatation, and the stent thrombosis in the next few days. And that may potentially be a nickel allergy. We just don't know.
I think, Raj, I think it probably has, in my mind, it may have more to do, because remember, the postulated mechanism of this is inflammatory cytokines, IL-1, IL-6, TNF-alpha. And so I think it might have to do perhaps more with the amount of the nickel that's exposed to the endothelium that really becomes more important, which is why I think that, as you point out, nickel-free devices, nickel-protected devices, stitch devices, as you start to talk about, and probably why PFO is where it reared its ugly head a little bit more, is because there's an awful lot of surface that and exposure. But as you start talking about long stents in the SFA or that sort of thing, you may approximate the level of nickel exposure, and so the inflammatory cytokines certainly would be similarly expressed.
Well, thank you very much, Brian. We are going to continue with this conversation in future. I'd like to continue our program. Let's get to the next topic now. And it's an honor and privilege to have Dr. Mustafa Zaman from Bangladesh, who is the president of Bangladesh Interventional Council and a BIC C3 Congress, which is really growing in popularity. It's being presented in February 24th, 25th in Dhaka. I've had an honor and privilege to be part of it. He's a senior interventionalist in Dhaka, very well known. He also has his own TV show. So it's an honor to have him today. He's going to talk to us about a complex case. Today is actually a Dhaka's Victory Day. So I want to congratulate him and everyone who is joining here from Bangladesh today. So great to have you, Mustafa, and I'm going to turn it over to you now.
Thank you, Dr. Raz, for nice introduction. Please start my video. Hello.
Yeah, we can see your slides.
We got you.
But
We don't see a video.
but video from your side, maybe this is stop.
No, we have no control
No.
over your video, so it's
Oh,
all in
okay.
your computer.
Oh, okay. Okay, just a minute.
I think if you go into the slideshow at the very bottom,
Okay.
it will play
Slideshow.
right there.
Yeah. But
So at the bottom of that video, there should be a thing to click on. So click on that.
but yes, but not the video, not start. The monitor showing you cannot start your video because the host has stopped it. The monitor is showing you cannot start your video because the host is. No. Raj,
I haven't done a thing, I have control over the whole thing. Because this is all in your computer. Everything that we see, it's
Okay.
what your computer is playing. So I'm not in control of your computer whatsoever.
Okay. Start monitor. No. Yes. Okay. Thank you, Raj, for your nice introduction. Let's start. It's not over.
So we can go to the next
Yeah.
slide.
Thank you.
Yeah.
Thank you. Thank you for nice introduction. Actually, I will present a case how to manage a thrombotic complication. It's a cath lab nightmare. So we know the thrombus is a very challenging for every interventional cardiologist. 70 years old, hypertensive, diabetic, and dyslipidemic patient, experiencing class 3, CCS class 3, and normal ejection free LVF, and underwent CAG by TRA. Then you see the angiogram. It's a mouth-watering lesion in the LCX, is severely stenotic lesion, and so next. This is normal, and LED is mild, mid-early lesion, but not significant. So the only significant lesion is LCX. So it's eccentric lesion. Next guide engagement was then wiring us into LCX. Our plan is to only LCX standing. But after ballooning, we'll see the patient is suddenly develop thrombus in the LCX and ostium of the LED and distal ligament also. So patient sudden develop hemodynamically unstable also. And then now, what should we do? Maybe.
Yeah. So let's pull the panel, Mustafa, and ask them.
Yeah.
About what may be their approach now. So I have one question before I allow any panel member to ask you any question. Is what anticoagulation was patient given? Heparin, bivalirudin, 2B3A, anything like that?
Yeah. First, when we started, there's a heparin, but after a complication with thrombus, GP2B3 inhibitor is given for the preparation.
And the patient became hypotensive and having chest pain.
Yeah. Yes. Patient actually experiencing hypertension and chest pain also. ECG also changes ST elevation. So at that moment,
what do you think? What would you do?
Actually, it's the emergency cases. So our plan is two. Number one, it is not the time to thrombus, actually thrombosection or like this, or our plan is, then we decide if we do only two-stent strategy or one-stent strategy. Another thing, that's what's went wrong. Maybe catheter induced dissection also in the distal left main, or maybe. So the heart team actually, we can decide that we'll proceed two-stent strategy, because one is LCX problem, another is LAD also, the dissection also we have seen. So next step we'll see the where is the LAD also wired, and after giving the GP2B3A, the scenario is changing dramatically, and now we can decide what should we do, and you will see the possible dissection along with plaque disruption and thrombus extending in the left main also.
So Mustafa, can I
imaging,
stop you for
yeah.
1 minute?
Yes.
Kirti, what would you do in India in a situation like that? Thrombus aspiration, angiojack, or so one option, of course, is to go ahead and put 2 stents in, just like what Dr. Zamani is suggesting, and get it fixed. Yeah, it seems like that the both vessels have TV3 flow. Any other alternatives, Kirti? What do you think?
So I think typically something like this, when it happens in the course of a procedure, most of the times the thrombus is developed in the guiding catheter, and you probably injected it into the into the left main, and I think that's the source. So having corrected all the status of anticoagulation and stuff, I think the first thing would be to aspirate that thrombus out. And if it's right in the left main, the one thing that comes to my mind directly is just use the guiding catheter as an aspiration mode, dig it in, and just do a good aspiration with a 20 or 50 cc syringe. And most times you will clear that thrombus. And once you do that, change that guide, bring in a fresh guide and a fresh place, and start the procedure all over again. I think that's what comes to my mind. But trying to put a stent into this immediately, keeping that thrombus there, has this small chance of embolization and causing distal microvascular occlusion, which is rather difficult to treat, and that's where you don't want to get into that space.
Okay, so one option would be that it's better to do some kind of a thrombus aspiration before proceeding with intervention. So Mustafa, tell us further about what then happened.
Thank you. We also discussed about the thrombosection, but the time is actually so limited because patient is deteriorate suddenly and gradually. So after giving the GP2B3A, and we do not change that, because we started with the 6 friends, because the initial strategy was 6 friends and there was a single stent strategy in the L6. But now we can change the to 7 or 8 friends. So we are with the 6 friends also. So now bail out the two-stent strategy, inverted tap in the or so left main to LCX strategy 3.5 into 3. So my question, anybody can say without imaging how we can actually take the stent size 3.5 into 30, because if our plan is from LCX to left main, and the diameter disparity between the LCX and LAD, we'll see. So our decision is LCX to left main and then LAD. So let's see. So LCX to, when we put the stent in the up to ostial left main, the LAD got totally occluded with residual plaque and thrombus propagation from its near ostium. So no time to pot, immediate rearing the distressed LAD. We'll see. Again, GP2 to be 3 given. Still now scenario is like this. And they took another 2.5 into 10 NC balloon. At least now TME flow was established after the near ostial ballooning. So new reality, mobilization of plaques from here and there, stationing in the application, you will see the nitrate GPA did not work. Again, repeated ACT showed satisfactory anticoagulants too. So needed an extra long DS for inverted tap. And starting with pot by 4 into 8 millimeter NC balloon, you'll see. And another 2.75 into 38 millimeter stent in the LED. So then the little pullback of the balloon from LED, and after kissing by the instant balloon and the other balloon in situ in the LCX. The final part you'll see, and after IVAS, we'll see the stent was expansion was good, and there is no male apposition we can see. So after the final, the patient is stabilized, and we'll see the final result.
Well, Mustafa, you are a great interventionalist, so you got this done very nicely in a very challenging situation.
Yes, catheter manipulation coaxial latmanostium while doing even a simple piece is very important, and Letman bifurcation to trade professional versus systematic or two-stent strategy already is everybody's actually decision in cath lab. So sometimes iatrogenic complication engraves the scenario, simpler way to be adapted. So nothing is simple. You always keep simple, but sometimes it is very, very important to keep simple. The tap or inverted tap is relatively simpler. For that reason, this study we have taken, and I'm inviting everybody's the C3 conference in Bangladesh to be held in 23 and 24 February in Dhaka. Thank you again, Raj, and everybody's.
Great. Thanks so much, Mustafa. It was very nice. Any comments from any other panel members?
Can I ask you whether somebody might have used Cangrelor just looking at that vessel to start with?
In the defense of Dr. Zaman, Cangrelor is not available in Bangladesh, but yes, in the United States, it certainly could be an option for sure.
Oh, no defense is necessary. That thought process only came after the complication in my mind, not before.
Yeah, so just to remind everyone about Cangrelor, which is an ultra short-acting IV antiplatelet therapy, which has been tested in United States in clinical trial. It's available and it's approved. And the advantage of Cangrelor is that it within seconds it will give you a 90% plus platelet inhibition. And then once you turn Cangrelor off within an hour, you begin to receive your platelet function again. So if you think about, the traditional glycoprotein 2B3 inhibitor and heparin combination studies, including infused AMI, one of the biggest reasons why these patients had groin bleeding or any other internal bleeding, at least in our experience, has been that this 2B3 inhibitor half-life was quite long, both in case of F6imab, which is RioPro, as well as Integralin and Agrostat. So once you give it, you're committed for some time, and that led to a lot of bleeding, which is where Cangrelor has been a great option, because you give it, and then if there's any issue related to bleeding or something, you can discontinue the infusion and hope that your oral antiplatelet therapy has taken over. So it's a great option. What I would probably do in this case, and if the patient's obviously crashing and is hypotensive, then immediate action would have to be taken. But I think that I would have tried to probably do some form of thrombus extraction. I'm not, a huge fan of aspiration thrombectomy devices because they're not universally effective. But a mechanical thrombectomy, such as Posse's Angiojet type catheter, which is now being sold by Boston Scientific, would be a great option and that would clean up this thrombus really nicely.
yes, thrombosuction may be one option, but and another IV cannula is not available in Bangladesh. So everything we can do, but every scenario is different for every in cath lab. So that's time actually that time we have decided to this way. So hope it's a different way in different cath lab we can manage this patient.
No, that sounds great. It's Dr. Assad sends you congratulations, Mustafa, for outstanding work. That's great.
you.
Okay, thank you so much. And once again, February 24th, 25th, Bangladesh BIC3 in Dhaka. So looking forward to the great meeting. So now it's my honor and privilege to invite Dr. Sandeep Nathan, who is Professor of Medicine at University of Chicago. Program Director for Interventional Cardiology, a senior interventional operator who's added a tremendous knowledge to the field of cardiology and interventional cardiology and hemodynamic support. He is a course co-director of the C3 Congress and a great friend. So thank you very much, Sandeep, for taking a time out of your busy schedule to present this morning.
Raj, thank you so much. It's wonderful to see you and so many friends. It's my honor to present here. Can you see my slide okay, my title slide?
Yes, we see perfect.
Great. So, I'm going to discuss a case that came up recently and, really sort of expose some of the challenges and pain points in STEMI intervention. I always sort of joke with the fellows that in our lab, STEMI is the simplest, most straightforward case. There's one problem, it's clearly identified, and usually one solution for it. But I think when left main bifurcation disease is in the mix, it becomes a little bit more unpredictable. So here are my disclosures. So the patient is a 80-year-old woman who presents via EMS with crushing substernal chest pain for several hours. Past medical history, as you can see, is dyslipidemia and hypertension. CAD, she had a PCI a couple of years ago in 2019, and interestingly, had a cath in 2022 at an outside hospital that showed what was deemed to be a stable 70% lesion in the circumflex. It was not intervened on for reasons that are unclear, but she was noted to have at that time heart failure with improved ejection fraction as high as about 45%. Also, history of ESRD, status post cadaveric renal transplant on the right side. We weren't aware of that at the time that we went to the cath lab. Bleeding diverticulosis, also not aware of that about a year before, but no bleeding since. And also of interest, she had an admission 1 week prior for sharp, what sounded by the medical records to be non-cardiac sounding chest pain. She was ECG and biomarker negative and discharged without a repeat cath at that time. Here's her ECG when she presents. I think it's there's a clear problem now. It's no longer non-cardiac chest pain. She has inferior ST elevations and some reciprocal depressions and one in AVL. She's quite bradycardic to about 40. Her blood pressure is a bit on the soft side, 90 over 100 on prior admissions. Her blood pressures were in the 140 to 150 range, so clearly a change from her baseline. She was loaded with aspirin and clopidogrel, as well as unfractionated heparin was given in the ED. Ticagrelor was deferred secondary to her bradycardia. Prasugrel was deferred secondary to her age, and she was started on dopamine 2.5 micrograms for blood pressure and heart rate as she was being rolled out to the cath lab. Here's her initial labs. You can see that she has some anemia. Her platelets are okay. She's already building a high sensitivity troponin, even with just a couple of hours, 2 hours or so of chest pain. NT-proBNP is up as well. And creatinine is up at 2.81. She's known to have stage 4 CKD despite her kidney transplant, which is now almost a decade old. But again, some of the more nuanced medical history was not known to us at the time that we went to the cath lab. So here's the angiogram. You can see that the RCA is sort of small to medium size. Nominally, it is a dominant vessel. It does give rise to some septal perforators, but nothing much to see here. And given the magnitude of her sort of hemodynamic compromise and symptoms and so forth, we're not really looking for tiny little branches that are out. When we shoot the left system, however, the problem becomes apparent. You can see that there's haze in the distal left main going into the LAD. The circumflex is not seen at all. And in the third image, you can see the stump of the circumflex. It's the latter two images are sort of angulated, AP crani, LAO crani, and quite a lot of mitral annular calcification as well, and fairly sluggish flow. So, maybe before I go on, I can turn it back to you, Raj, and have the panelists sort of share some thoughts on approach to PCI and circulatory support.
Yeah, that's a fantastic case, very difficult. Anybody wants to express their opinion about what they might would do?
I'm just thankful that I have taken a non-STEMI call position late in life. That scares me.
Mustafa, what would you do in Bangladesh, or Kirti, what would you do in India on a situation like this?
So, Sunny Pai, Kirti here.
Hey, Kirti.
Hey, so what's the hemodynamics telling you? I mean, are you inching towards a mechanical support, trying to put her on some mechanical support device? I mean, left ventricle and diastolic pressure, systolic pressure, I think I missed that, aortic pressures, and
yeah, her initial pressures were in the 90s over 40s in the ED on a little bit of dopamine. She's perked up. Her heart rate has not picked up, but her blood pressure is about 100 to 110 at this point. And we briefly dipped the ventricle, and LVDP was about 20. So not super elevated at this point, but clearly she's off of her baseline.
So I think, given those hemodynamics, I think the best thing is to establish, you see that ostial circumflex totally occluded, and once you get the wire in, I mean, my big issue is that must be largely thrombotic. And how do you deal with that? In my cath lab today, for me, these are the kind of cases that I would use an excimer laser for. And I would take in I could even take in I didn't see much calcium in the coronary space, really. I saw them more in the annular space. I mean, I saw annular calcium, but I couldn't appreciate the coronary calcium. And so if the passage is okay and the wire doesn't show much tortuosity, I would even go with a 1.4 catheter, but otherwise a 0.9. And the reason being that the problem with aspiration is that you have the small risk of pulling it back into and putting it into the LAD or even in the aorta with a stroke. And excimer laser is likely to, I mean, our experience with excimer laser has been exciting in this. And a very quick establishment of TIMI3 flow is what you need to give you space and time to kind of build a strategy around how you're going to complete the case.
So, Dr. Nathan, a lot of people who participated in your poll are actually online. We have a solid attendance this morning. But to remind you about the choices which were given for the poll for this case.
I got it. I have it on the next slide, Raj.
Okay, great. Maybe you can share that. Yeah.
Let me just go to the next slide. So this is a poll, as Dr. Dave mentioned. I put it to Twitter, obviously not while we were doing the STEMI. The poll came a little bit later, but just wanted to see what everyone would think about stabilizing this patient and going to emergent bypass, just doing PCI of the circumflex without stent implantation, and then urgent bypass. Definitively fix the circumflex one way or the other. And Kirti, I love the idea of a laser. We didn't use it in this case, but we have certainly used laser for resistant thrombus. And you're exactly right. I mean, it's amazing how well it vaporizes thrombus, and I don't think it's pulled out very often in this capacity. Third choice was DES of the circ, definitively fix it and then stage the LAD PCI. Or fourth option is you go all in and try to fix the left main and make it look right plus minus mechanical circulatory support. I've listed some key technical considerations on the left side of the slide. And, essentially you've got two buckets. You've got left main equivalent disease. However you squint at this, you have to acknowledge that LAD is part of the problem. It's not just the circumflex, although the circ is thrombotically occluded. And, one would infer from how sick she's getting that perhaps it's a large territory. And the second is that she's HFrEF and now stage B cardiogenic shock just beginning, and fortunately responding pretty well to a whiff of dopamine. And so that's where the indecision sort of comes in. I will also say that her periphery doesn't look great. Her periphery is quite calcified from her years of ESRD before her kidney transplant and CKD after her kidney transplant. So the periphery doesn't look great. Her radial arteries are sort of pretty faint.
So, Sandeep, I don't know whether Dr. Metrovic is still online, but it'd be a great question, whether to utilize a mechanical circulatory support, and in this case, I think obviously the options are either balloon pump or Impella to stabilize the patient and to improve the safety of the intervention. I don't know what a femoral looks like, but I'd probably say I would consider doing Impella. George, are you still here?
I'm still on the line, and would certainly support doing support. I think if you're going to do it, and if the access is reasonable, I think the Impella provides a lot more support. This patient looks like they have a lot of potential for not only the just general management, but if there was a problem, it would certainly give you a lot of time to work your way out of it. And that's kind of one of the interesting things. Everyone always says, well, you don't need it most of the time. And if you look at the mortality for patients who don't need it but get it urgently versus those that have it in electively, that they do a lot better. So I think it's a good thought, Raj.
So one question I did want to ask you for our audience is that, George, what are the key hemodynamics parameters that comes to mind when you decide in an emergency situation? And same thing for Sandeep as well, that you guys decide, that we really should go ahead and put a if Impella, if it's available, and if not, in a outside the country, would be intra-aortic balloon pump.
Well, I certainly for the all of them is, I think, hypotension, and particularly a high filling pressure, however you get it, if you put a right heart cath in or if you just measure it going into the ventricle. I think the high filling pressure, particularly in an ischemic situation, is a real negative, because the first thing I learned in cardiac physiology in medical school was that, the greater the wall stress, the greater the oxygen consumption. So in an already ischemic patient, that's a really significant negative. So the combination of hypotension, poor perfusion, plus this increase in filling pressure, I think is a real trigger.
Sandeep, what did you decide to do in specifically as it pertains to mechanical support?
Yeah.
Was anything used here?
Yeah. So thank you, Dr. Vetrovic, for your comments. And all of these thoughts were sort of going through my head at the same time. We discovered at that time during the femoral angiogram that she had a transplanted kidney on that side, along with some calcific disease and some narrowing and so forth. So we prepped the other groin. I completely agree with George's comments that if you're going to use it, it's better to use it up front rather than bail out to it. But we did end up bailing. We did end up with a provisional plan to use it, and partly it was because on 5 mics of dopa, she's now still quite bradycardic, but she's got a blood pressure of about 120. So we bumped up her dopamine and we said, okay, look, let's just get started. It's a huge circumflex just by territory, likely, and let's see what happens. Let's wire it, let's balloon it, and if we're sort of limping along, then I think we just go ahead and put in Impella. So, we went ahead and stopped the clock and ballooned the circumflex. And before I go to that, I'll just share with you, this is how 155 respondents voted on this Twitter poll this week. DES of the circumflex, so definitively fix the circumflex and stage an LAD PCI. I'll share with you at the end some data on left main intervention in STEMI that was published a couple of years ago. Okay, so I think dealing with this begins with an understanding of bifurcation anatomy, and by definition criteria, complex true left main bifurcations are Medina 111s and 011s. I think you could argue that this is a 011, not too much extension into the main trunk of the left main, but almost certainly you're going to have to cover all of it. By IVUS data, 90% of left main bifurcation disease does involve the LAD. Whether you see it or not, there is a significant amount of atheroma that has to be taken into consideration. Here, there's absolutely no mystery as to what the distribution is. Provisional one stent strategy is nice to talk about, but I think that when we're talking about high-grade LAD disease, in addition to an occluded circumflex, I didn't see any likelihood that we would be able to just nail the ostium of the circ and get away with it, which means that you are into the left main, which means that the likelihood of side branch compromise, side branch in this example being LAD, side branch compromise was almost inevitable. And conversion to a two-stent approach at that point, Dr. Zaman very elegantly showed a T in protrusion, but I think that, with the amount of disease there, a prior stent, which may or may not be well expanded in the proximal segment, this did not seem like a great sort of provisional case. However you approach it, whether it's TAP, T-stenting, or culotte. Practically speaking, I think there are two contemporary two-stent strategies that may be considered. One is culotte, with the distinct disadvantage of losing control of the main branch before rewiring, and then of course DK crush, which is validated in literature, although there's sort of a difference of opinion between DK crush 5 and EBC main. However, much more labor intensive, and so for a STEMI sort of shocky patient, that's an added consideration as well, that the numerous steps required to get this right may not be compatible with a critically ill patient. And the last slide I'll show here before I show you what we did is the EBC MADS2 classification from the white paper that was published in 2020, kind of going through MADS main across the side branch, double proximal lumen and side branch first approach to left main bifurcation disease. And as I said, this was published in 2020 in CCI. So we went ahead with primary PCI, and there was maybe 5% of me that was wondering, if we just open up this circumflex, we'll realize that we can nail the ostium of the circumflex and come back to fix the LAD. Two things became apparent: A, that wasn't going to happen, and B, the circumflex wasn't going to stay open. So we would balloon the circumflex, and the STs would resolve, her blood pressure would go up, and then it would close again pretty much immediately. The circumflex would close, the STs would go back up, the blood pressure would drop. So we played that game for about 2 or 3 cycles of balloon inflation and deflation, crossed pretty easily with a Caravel microcatheter and a 300 centimeter run-through wire. And as I said, we had prepped the left side for MCS, hoping not to put a large sheath across the transplanted kidney. And so then more ballooning, and this was the point where I said, okay, we're all in. We're just gonna take care of all of this. Hopefully we don't need to do too much calcium modification. There's clearly thrombus there. Shockwave would certainly be a reasonable choice if we need calcium modification. But to Kirti's point, in the initial pictures, it didn't look like there's that much calcium. I think some of it was hidden by the MAC in those views. You can see in these pictures that there's quite a bit of calcium now that's apparent, but none of it seems to be circumference. So at least on the angiogram, we get IVUS images later. So now double wire, and we're ballooning into both. The STs have, interestingly, the STs got better after we ballooned the LAD and the circumflex, and they stayed gone for a while. Now we're IVUSing the circumflex, and you can see the patches of calcium, but none of it seems to be 360-degree circumferential calcium in the circumflex coming back into the left main. And so I think that gives us multiple options: NC balloons, shockwave IVL, et cetera, things that don't involve a rotablator burr. And we also got some sizing and calcium information. The circumflex in the landing zone was 3.5 by 3.7. So now we've got our 3012 balloon in the left main to the LAD. We've got a 3.5 by Onyx Frontier sizing up to the distal vessel in the circumflex. And that's deployed at 16 atmospheres. The DES and balloon, the DES balloon and the wire are removed. And now here's our crush, 30 by 12, and the circ rewired into the circ is rewired, and the balloons are positioned for our first kissing balloon inflation at 3.5 by 12 NC into the circ. A fresh balloon and a 3.0 by 12 NC that we use to crush remains in place. And so here's our first kissing balloon inflation at 18 atmospheres into the circumflex first, and then kissing balloon inflation with the 3.5 and 3.0. Next, the circ wire and balloon are removed, and a 3.0 by 18 Onyx Frontier was advanced again, sized to the vessel using IVUS, and overlapping by about 2 millimeters into that old stent that you can see that was from 2019, and deployed at 20 atmospheres, potted with a semi-compliant balloon 4.0. And then in the second image, what you see is that winged 4.0 balloon pushed forward and being used as a bumper to help us find the ostium of the circumflex for rewiring. This can be a bit challenging. The knuckling is deliberate. For folks on this call, you want to make sure that you don't end up underneath the stent strut before you re-enter the circumflex. So we deliberately found a cell where we can kind of knuckle the wire and then sort of probe the left main stent, and then find our way into the circumflex. And that was rewired using a 300 PT2 MS. Second kissing balloon inflation. Looks pretty good, but IVUS always humbles you, and there was still some under expansion in the left main, and so whereas we had used a 4.0 semi for pot, we used a 4.0 NC here and dilated up to 20 atmospheres, and this is the final technical result is pretty satisfactory. Both my angio and IVUS, we didn't lose any branches. The neocarina looks good by IVUS as well as angiography, and now the patient's hypertensive on 5 mics of DOPA. Here's a paper from a couple of years ago that probed the national inpatient sample of 160,000 patients with a primary diagnosis of STEMI in 2016. Only about 0.3% of them had primary left main involvement, and not surprisingly, left main PCI, left main STEMI was associated with a higher rate of cardiac arrest, cardiogenic shock, acute organ failure, and worse in-hospital outcomes than non-left main STEMIs. About a third of these patients underwent bypass surgery, and compared with prior studies, there were lower rates of cardiac arrest and cardiogenic shock in this. So, things maybe are moving in the right direction there, but, there hasn't been that much improvement in outcomes in left main. So 0.3% in this analysis is a low number, but it's a non-zero number. And I'll tell you that we've had 3 of these. They come in clusters, and we've had 3 of these in the past 6 weeks in our lab, left main interventions in the context of STEMI. The epilogue here is that the patient actually did very well despite her advanced age and numerous comorbidities. Dopamine was weaned off in the cath lab. 6 French sheath was removed. She was loaded with Tycag at the end now that her heart rate had normalized. We continued cangrelor for about 3 hours, 1 day in the CCU, 2 days on the floor. No AKI, bleeding, or readmissions in 1 month. Fingers crossed. Thank you so much.
That's great. Thank you very much, Sandeep, for that outstanding case. It really is a testament to your incredible skill that you were able to do this in such a nice way. A great case. There is a Dr. Harris from Malaysia. Have a comment. A primary PCI without MCS support in AMI. Cardiogenic shock in this patient. It seems the patient can tolerate the procedure well. Congratulations and well done. And I echo Dr.
Raj,
Ma's
I have a question.
comments.
I have a question.
Kirti, Mustafa,
I have a
any
question.
comments?
Yes, I have a question actually. In STMI platelet bifurcation patient or any complication situation, twist and strategies, case of true bifurcation or non-true bifurcation, which is mostly done in USA or India. Because in our country, we know the TAP is very easier and very simple procedure than culotte or decay crash. But in this country, subcontinent, we mostly use the TAP or inverted TAP. But I want to know in this scenario, in your scenario or in mostly in India also, which twist and strategy mostly used?
Good question. Kirti, India question, I don't know. I don't know whether Kirti knows some top line data about what's the most common bifurcation strategy being used.
So I think for the most part in an emergency, most people are wanting to use the quickest. And I think in this scenario, the culotte is probably preferred. The DK crush is a little more exhaustive in terms of the kind of steps that are involved. And so I think people might not resolve to those in the acute scenario. But having said that, if I allow myself a comment, I think Sandeep, that was an outstanding case. I mean, brilliant to end with. My question is just one that we've been trapped with looping the wire and trying to assume that it is going to be within the struts of the stent. And even the loop actually sometimes is substrut because it just follows the wall of the artery and never the lumen. And so after we've put in our first stent, I think we do take a pause because by then we've stabilized the patient well enough to then make it a regulation left main angioplasty and putting in an IVUS catheter and making sure that the left main struts are pretty much well opposed before you put our second wire in is a key to our left main story, because the most part when you convert a single stent strategy into a 2-stent strategy, the biggest problems that we see is the deformation of the stent from a abluminal wire position at any time through the shaft or at the carina. And it's very easy because the new balloons are so low profile that they would still cross and they could deform and lift off a strut without us realizing. So for me, that has become a crucial part of the left main strategy, is that assessment of the left main shaft and its apposition, the stent apposition of the first stent before the second wire goes in. But otherwise, you demonstrated your skill so beautifully. And I mean, it's difficult to get these kind of results in these very sick patients. And the patient's done well, which is fantastic.
No, thank you for the comments, Kirti, and the kind words. It was a tough case, and I will tell you that multiple times along the way, my fellows and I kind of discussed, what is the shortest path to success for this patient, just in the interest of getting this open and getting her off the table. But I think the flip side of this is that, she is sort of independently living, doing well at home. She's survived a lot of medical issues. And I thought this would be the most durable fix. The one wild card in this is how much calcium would be in either one of those ostia. I think that completely changes the dynamic of every 2-stent technique, certainly DK crush. And so I was kind of dreading when putting the IVUS down, if we saw circumferential calcium. Now we're in it for for a little bit more work than we planned for. But the fact that we were able to get the IVUS down, after pre-dilatation with NC balloons, gave me some hope that we should be able to take care of this without atherectomy. I, like you, maybe not as much as you, are very enthusiastic about rotablator and have plenty of experience with it. But even without visible thrombus after you clear it, I'm a little bit leery about using rotablator here. I don't know what your thoughts are, Kirti.
I don't think you needed it. I think once the IVUS cath, once you've established crossability, the yield of a rotablator in these kind of cases is very low. And I think you've already transferred your care to the next layer of calcium, which is what is going to affect your expansion more than crossability. So I think all the ablative techniques for me are to resolve crossability, and most of the other device modification techniques like IVL and Wolverines. I'm a very fond of Wolverines somehow. And that would have been my first choice, 1:1. But I can see the differences in practice in various geographies. But I think I wouldn't shy away from IVL2 to get the best expansion before I put my first stent in. But I think, the winning way is the way that actually wins. And you did that. So there's no questioning a great result, really. Sandeep, you did a phenomenal job.
Thank you. Thank you so much.
Well, great. Thank you so much, everybody. Fantastic. This has been a great show today. We have pretty much, almost majority of the continent present here, from Asia to, South America to US. So I thank all our participants to take time out of your busy schedule right before holiday time to be part of this session, because you are the ones who are making C3 Live come back. And thank you very much for your patience for such a long session today. I want to thank all our esteemed faculty members, Nihar, Sandeep, Kirti, Mustafa, Dr. Vetrovec, Dr. Clark, all of you who's taken a lot of effort to put together these presentations. Excellent topics. And thank you so much, everyone. I look forward to seeing you again on January 20th, which will be our next show in year 2024, and continue to have all of you actively participating again in future. So with that, I'd like to close today's session. Happy holidays, Merry Christmas, and Happy New Year to everyone who's joined today. Any of the panel members want to say anything, please feel free to do so.
Just good holidays to everyone, and thanks for joining. And I personally will appreciate any feedback on my presentations. Thank you.
Thank you.
Thank you, Raj. Really, thank you for getting all of us
Nice
together.
presentation.
It was really a pleasure.
Great.
Thank you very much.
Take care. Have a great weekend.
Bye-bye.
Thank
Bye now.
you. Bye-bye.
Bye.
Thank you. Oh my, no. Whoa, what do you want? What happened? Daddy's coming. Papa, you want the music? You want the music, Mama? Okay. What